Hey everybody, I want to talk through the CETC for September, kind of all get on the same page. Remember, the goal of the CETC is just to provide the students a step-by-step thinking process, how to break down a movement pattern. You want to do, the way the model works is if-then. So it's not SFMA based. If you don't do SFMA, which is fine, but just I'll go through why and how I picked this. But whatever system you use, make sure you're very systematic to break down the squat. So you have the history, the basic reminding that this is the non-irritable condition. You know, it takes her 2 miles. It's not that pain-driven person. Inspection, the obvious component of it. So let's look a little bit more into the squat itself. Again, it might seem a little odd. It's not a typical squat, but think of it as a screening exam. So basically what you're trying to do is screen to rule out lower quarter dysfunction. So this is not how you would obviously teach a patient to squat. So the key to this pattern, and the reason it's consistent, we can reproduce it. And then you might say, that what if they have anteverted hips? What if they have other issues going on? Well, you pick it up in the breakout patterns, which come up next. We'll go through it, and I'll kind of go through the chart, so hopefully it makes a little more sense to you. So here's a squat. She comes down. She goes past. You should at least get past parallel from the front. If she does it, then you can have her put her hands down. They have to stay within her footprint. If she could reach the ground with her fists, that's normal. So directions to the patient: bring your feet together, parallel, arms straight out, the head, squat as deep as you can. If they're able to get past 90 degrees, they meet the criteria. Below we'll talk about it. Reach the fist to the floor. Criteria: if it's painful, they don't pass. The hips don't break parallel, they don't pass. They can't reach their fist to the ground, to the footprint, they don't pass. They've lost of some of that valgus or varus thrust, so to speak. They lose it left or right, they don't pass. Or if they have excessive effort, weight shift, or motor control issues. So what is this confusing chart? So here's how you break it down. So somebody, when you get to that chart, that means they failed this. So if they failed this, now we're going to say, is it an ankle problem? Or tail curl, subtalar, knee, hip, etc. We break it down. So let's see what things mean. So this person couldn't do it. So let's do that. The tandem dorsiflexion test. They should get to about 40 degrees, right? They have their feet lined up with each other. You're testing the back leg. It goes, have them go forward. Should go past it, almost to the malleolus on the other side, or 40 degrees. If they could do that, functional normal, then they move on to the next test. If they can't do that, you can put them prone or whatever position you like. Here's prone, and then they test it with the knee bent. So we're thinking more soleus or joint. Dysfunctional painful, or functional painful. If there's pain, then we stop, and we start to treat the pain component. Is really inflamed, etc. So that's an ankle problem. Then we stop and we test some more. If it's functional normal, they couldn't do it. They couldn't do it actively, but passively they could. Think of a motor control issue, a stability motor control deficit, or if they dysfunctional normal, they can't do it, or dysfunctional non-painful, sorry, they have a dorsiflexion mobility deficit. Then we move on. Now we're testing subtalar joint. If that's normal, we move there. Functional normal. Passive, if it's dysfunctional painful or functional painful, again, we treat the pain. It's a pain-driven problem. If it comes to here, if it's functional non-painful, but they couldn't do it here, but they could do it here, then think of a stability motor control deficit. And if we go into here, it's dysfunctional, normal, and some mobility. And think of the same thing as we go down. We could do it through the components of it, just break it down the same way. Little review: functional non-painful, dysfunctional painful, functional painful, functional non-painful, dysfunctional non-painful. All right, so a couple of key points we do when we do our testing. So we talked about this one. The toe lines up with the heel, 40 degrees. This has to be at 40, that component of it, or this passes the opposite malleolus. Dorsiflexion, knee flex, passive testing. One of the ways, Taylor swing test. Okay, your thumbs go in the front. The index fingers go behind the malleoli. You're on the talus in the front. Then you have them, you do it. You passively go from plantar flexion to dorsiflexion. Keep the foot parallel to the ground. And then you're looking for early movement. They shouldn't, probably when they get to about neutral, you should start seeing it. If it just goes back and just locks, then we're starting to think maybe there's a tailor issue, tailor posterior glide issue. Then here's the passive testing prone, and then pterocrural joint AP glide, the way Joe's doing it, right? The typical pattern. Sometimes we'll also do, so you're doing a glide where you're going through, you're going in the web space and you're going through the glide. One of the tricks also sometimes is take the talus, the calcaneus, give it a little bit of a inferior glide or towards the ceiling to lock up the subtalar joint, and now you can do a better motion at the pterocrural joint. You can also teach the patient, you can also teach the therapist to come in, use the base of their hand on the talus coming from the bottom and do their glide. Kind of a nice way to feel it. We did that. Now, subtalar joint has an anterior joint and a posterior joint. If you can see it, I'm not sure. So the one joint is going to be more of the anterior joint. It's going to have more of a inversion, eversion motion, where the posterior joint has more of a rotation, and it's going to actually look, it's going to have that. It's going to AB and adduction of the forefoot. So we know the subtalar inversion, eversion, and then we could do just rotation through the talus, the calcaneus on the talus, just a rotation. And again, when you're doing it right, you should actually see the forefoot AB and adduct as opposed to inversion, eversion. It would be more like that motion. And that's kind of a nice way to do it. And the way you would typically do it is go to its end range, like, and then take it up, try, and do they have that spring rotation, take it up. And you'll see that the posterior joint, a lot of your patients who don't have the ability to get their glutes to activate, they can't get that rotation, that normal rotation through here. Right? They can't get that component, and they lose glute strength as well. Knees, that's the easy one. Knees to chest, holding their shins. Can they get, is it looking at the knee, holding their thighs, looking at the hip. Passive, you could do an active hip internal external rotation, just look at that range, and you can pick up all your versions in that. All right, the key is to take your time, go through it. Again, if you need to modify it because it makes more sense the way you think, but I really want them to have some type of continuous thinking process, thinking pattern. All right, have fun. Thanks, guys.